Good afternoon and welcome. Thank you for joining us today for our webinar, a multidisciplinary approach to the assessment, treatment and management of non-diabetic foot and leg wounds. My name is Katie Flanagan and I am the current podiatry manager for the Midwest. We are running a project funded through the Slaunch Care Integration Fund, SIF343, a podiatry-led pathway for the timely provision of footwear and orthotics in the community. This project has been supported by Slaunch Care and Pobol, but also by our local management team here in the Midwest. We are assisted ably by the Project Management Office and Finance departments also. We would like to extend all of them our thanks for continued support in this project. On the ground, we would like to acknowledge and also thank the constant work of our nursing colleagues, with whom we share the care for most of these types of patients covered in today's presentation. And finally, we would also like to thank our recently retired podiatry manager, Carmel Devine, without whom this project would never have begun in the first place. Before I introduce our first speaker, a couple of housekeeping points to go over. Number one, can you all please put your microphones on mute? It does stop interference during the presentation. Second point, all questions will be kept to the end of the final presentation, but please feel free to write them in the chat box as you think of them. All three speakers will be available to answer your questions at the end of the final presentation. And the last is a reminder that today's broadcast will be recorded and it will be placed up on YouTube. It takes a little time, but everybody who registered will get a link sent by Eventbrite to the email address you initially registered with. And like I say, that'll take a week or so. So to introduce our first speaker, Darren McLaughlin. She is currently our senior diabetic podiatrist in CHO3. Darren graduated from NUIG as part of the first cohort back in 2012. Within her role, she actively treats people with diabetic and non-diabetic foot wounds. She has been running the Rapid Access Foot Clinic in Clare since the first lockdown in March 2020, allowing vulnerable patients to be seen close to home, enabling the right care at the right place at the right time. Darren has previously held the role of National Podiatry Lead on the National Clinical Programme for Diabetes and is now the current project lead on SIF343. She has nearly completed her Masters in Leadership in Healthcare through University College Cork and the Irish Management Institute and expects to graduate this summer. Today, Darren will be talking to us about the management of non-diabetic foot ulceration in the community. Thank you, Darren.
Hello, my name is Darren McLaughlin and I'm the Senior Diabetes Podiatrist here in CHO3. Today, I'm going to talk to you about the management of non-diabetic foot ulceration. So hopefully this presentation will give you a framework for assessing non-diabetic foot ulcers when they present to the clinic and give you a guideline on how to manage these. So just a quick recap, a foot ulcer, as we know, is a full thickness wound through the dermis below the ankle. There's three big factors we need to consider. So predisposing, so why is someone susceptible to developing an ulcer? A triggering factor, which is what causes an ulcer, so trauma maybe or tissue stress. And what are the sustaining factors? So lack of blood flow, lack of protective sensation, combination of these, and infection. And there's two assessments that we need to carry out on patients who are attending who have a non-diabetic foot ulcer. So if you think about it, there's lots of reasons why somebody may develop a break in the skin or may be susceptible to developing a break in the skin. And because of that, a certain remit of my post is to look at these people and to treat these ulcerations. And two key things that I do in every assessment is a vascular and a neuropathy assessment. So for a vascular assessment, you're looking at medical history, whether or not maybe they've had an MI or a CVA, a surgical history to see how they had revascularization, maybe stenting up the heart, whether or not they have subjective reports of vascular pain. So I'm going to talk about this on the next slide, but it's looking at whether or not the lack of blood flow is causing pain. Can you palpate pedal pulses? So top of the foot and behind the ankle, dorsalis pedis and posterior tibialis. Can you Doppler them? So can you Doppler the dorsalis pedis, posterior tibialis, and perineal? Do you hear a good sound? Capillary refill, is it less than 3 seconds? And temperature gradient, are we a gentle gradient from warm to cool, or are we quite steep? In a neuropathy assessment, we're looking again medical and surgical history, subjective reports of neuropathic pain, we'll talk about on the next slide. And our 3 key neuropathic tests are light touch, so 10 gram molybdenum. This will indicate whether or not someone will feel a small crack, maybe or break in their skin. A vibration sensation, which is carried out with a tuning fork, and this will tell us whether or not a person will feel rubbing or friction. And hot and cold. And then there's pain. So there's 2 types of pain we look for and to see our patients reporting. The first one is vascular pain. So a night cramp is a cramp in the back of the leg, usually the calf, can be in the thigh or the buttocks, and it's when a cramp comes and it can only be alleviated by hanging the affected limb over the bed. This is a sign of peripheral arterial disease in the leg. Intermittent claudication is when patients will report a cramp in the back of the leg when they walk. This is usually at less than 100 yards, and it's useful to use local landmarks with patients when trying to determine if it's intermittent claudication. And rest pain. So rest pain is the most significant of the vascular pains, and it happens when a patient is sitting in a chair with the legs hanging down. They're unable to maintain this position for very long, and they need to get up and keep walking because the pain is quite significant. So these are patients who usually will not be able to sleep through the night, or they'll be reporting significant pain. They usually fall asleep in a chair, and they're usually on quite a significant amount of pain medication to manage this. Neuropathic pain can come from pins and needles, burning or freezing. You'll hear these patients report shooting pains, sharp pains, feeling like cotton wool. There's lots of different reasons for neuropathic pain outside of diabetes. They need to be considered really mostly from a GP point of view, so looking at a full blood screening to see is there vitamin B12 deficiency. Maybe there's central nervous system disorders like MS that need to be considered, or even something a little bit more common. So there's a sliding scale of foot ulceration really that we need to look at, from neuropathic to neuroischemic to ischemic, and they all have different goals. And while the literature is predominantly diabetes based, one key thing that we can keep from it is looking at VIP, which is vascular, infection, and pressure. So what is neuropathy? Neuropathy is an altered sensation due to damage to the nerves. This doesn't mean that it's a complete lack of sensation. It might just be the likes of the numbness, the sharpness, the pins and needles. So different nerves have different presentations. The foot may look very dry, could be very moist. Nails could be very discolored or very thick. There's usually callus built up on weight-bearing areas, and there's unexplained bumps or bruises. So an assessment will show an absence of a light touch sensation test or a vibration sensation test. Ischemia is when there is an insufficient blood flow to an area due to reduced arterial supply. Again, this is a cold foot. It can be quite dry. It's pale or sometimes the purple erythema. We'll cover that later on. And it's often very steep temperature gradient comes with that. It's very difficult to palpate pedal pulse if there is one in an ischemic foot. Capillary refill time would be more than 3 seconds. It's important to determine if this patient has medical or surgical history of revascularization or ischemic disease, and patients will usually complain of vascular pain, so that night cramping, rest pain, and intermittent claudication. Neuroischemia, as the name suggests, is actually a combination of the two, so when there's not only poor blood flow, but there's also neuropathy in the area. Again, patients are likely to have a cool, non-palpable pedal pulses in their foot. They're least likely to display any signs of infection, so that red hot swollen foot that sometimes we rely on to tell us is unlikely to be there. Their neuropathy and vascular assessments will all show significant deficiency, and there'll be mild callus, dystrophic nails, and they might be thin and dry hairless skin. An infection, which I'm sure we all know about, but the presence and multiplication of microorganisms which are not normally present in the body. So it usually presents with a red hot swollen foot. But when we're dealing with this cohort of patients who might be chronically unwell, be immunosuppressed, neuropathic, ischemic, we might not see these signs, and so we need to look further up the chain. So neuropathic ulceration, and if we look here on, this is the bottom of left foot, you can see where an area of callus has built up over a met head, so what we refer to as the met heads. And this ulcer here is due to pressure. That's usually what a neuropathic ulcer is from. So if we look at our VIP assessment, so V, vascular, do your vascular assessment. A neuropathic foot should not need a vascular intervention. So a neuropathic foot should have a palpable pedal pulse. Okay, it should be well perfused. I, you need to assess and manage infection. So if there's no significant red, heat, or swelling in the area, ask further up the chain. Have you been feeling well? Have you lost appetite? Have you noticed that you've got any vomiting, diarrhea, fevers, chills? And P. So this is one of the most significant things with treating a neuropathic foot, is that we need to offload this area. So this area won't heal until it's offloaded. There's a slide later on looking at offloading mechanisms, but it's important that you refer into podiatry for offloading. Dressings, so the goal is to keep this moisture balanced, so not too dry, not too wet. Considering offloading or like an offloading felt, ensure that the dressings are not too tight or rubbing because the patient won't feel it. So if you're going to use tape on the top or the bottom or even in between the toes, make sure that it's well secured down because the patient won't feel it if it starts to get loose and rub. And if it rubs in between the toes, it can end up causing a blister. This patient is also suitable for sharp debridement and will need that to remove that callus, so you can refer into your local podiatrist. Management, so we're looking at footwear and orthotics. Orthopedic referral may be necessary, and we're talking about patient education and regular review. So these are some of our offloading options, and if anyone from CHO3 is here, you might notice that top left-hand shoe, the offloading shoe, is definitely given by our department a good bit. So what we're looking at is trying to take the pressure off the bottom of the foot or wherever the ulcer is. So here in CHO3 we're quite lucky that we have a Sláinte Care project, SIF343, which is actually looking at giving people offloading in a timely way to try and take the pressure off wounds that need to heal. So you'll notice that when it comes to podiatry we tend to give out quite a lot of offloading options, but they're not always suitable. So we'll say for the top left-hand corner, an offloading shoe is suitable for somebody who has good enough steady gait. They can walk, we don't have a big fear of them being a falls risk or tripping. Down to the bottom left is a heel lift boot. That's ideal for taking the pressure off a heel ulcer, or taking off the pressure for someone who's maybe sitting for long periods of time or in the bed for long periods of time. Up to the top right is an air cast walker. These are a more hardcore version of the shoe, and what they do is they use air filled panels along the inside of the boot to hold the foot in shape. It also has quite a rigid back and a rocker underneath, so it takes the pressure off the plantar of the foot, the bottom of the foot. And felt padding on the bottom right, which is our staple. And you'll see where the U's are cut. In the case of the previous ulcer on the previous slide, that U is cut, so that wound is sitting in there and the felt is taking the pressure around. So this is a neuroischemic ulcer, a mixture of neuropathy and vascular. So when we look at our VIP, we'd assume that from the results of our vascular assessment that we'd need to refer to a vascular team. You'd expect this patient to have poorly palpable pedal pulses. The chances are that foot will be quite cool and very poorly perfused. So you need to assess and manage for infection. P, refer to podiatry for appropriate offloading like before. Dressings, the goal is to keep this dry, okay, and to consider again an offloading felt, and again to ensure that dressings are not too tight or rubbing. This person may be suitable for cautious sharp debridement, but the biggest thing that we're trying to do here is take the pressure off the area and make sure that enough blood is getting down to the area to heal it. So I mentioned before about an ischemic foot with erythema, so purpley pinky colour. So if you look at that foot on the left, from the bottom of the toes up to their top, you'll see that they're nice and pink. Don't let this fool you. So it's actually just dilation of the capillaries to perfuse that really superficial skin. So it'll look pink, might feel a little bit warmer than usual, but the blood flow isn't getting there any better than it is in any other part of the foot. So just as a little reminder. And this is an ischemic ulcer. So if we do our vascular and neuropathic assessment and we look at V, you're most likely need to urgently refer to a vascular team if it is an ischemic ulcer. On this foot here, you can see that the skin is quite shiny, the edges of that wound are quite punched out and quite defined, and there's no callus, so it looks like an ischemic ulcer straight off the bat. It's also not on a weight-bearing surface, which would be inclined to be a big telltale sign that it's purely ischemic. So assess and manage infections. So if we look here, you can see that there's quite a significant infection. There's blistering on the dorsum of that foot where the previous infection will have caused swelling. And P, we need to refer to podiatry for appropriate offloading. So it still needs to be done. So we just need to make sure that nothing's touching off this wound, that it's being kept in such a way that nothing's hindering it from healing. These ulcers are extremely painful. And something to note, especially with ischemic ulceration, is that sometimes it's not about trying to heal it, it's about trying to keep it in status for as long as possible. Some people do not have the capacity to heal and are not suitable for vascular surgery. So often these chronic wounds, we're trying to keep them there, we're trying to keep them on the books, and we're just trying to keep them from getting any worse. So the goal is to keep it dry. Consider the use of iodine or silver. Don't use anything restrictive like cling, and do not consider sharp debridement. This patient in particular would need an urgent referral to the vascular team in ED. In some cases, your patient might present with an ulcer that needs an urgent acute review. So if a patient is complaining of rest pain, if they're medically unwell, if the wound has been causing severe pain, if they're disorientated or confused, or if the wound has rapidly and significantly deteriorated, all of these are signs that the patient needs to present to the emergency department. So that's quite a lot of information in such a short session, but hopefully it will provide you with some kind of framework on how to deal with these non-diabetic ulcers that attend the clinic. And it might take away that kind of daunting element as well. So if you've done a vascular assessment and a neuropathy assessment, you'll be able to tell whether something is neuropathic, neuroischemic, or just ischemic. And I suppose the last thing to note is that sometimes wound closure isn't completely realistic. Sometimes people don't have the vascular to heal, or maybe it's just not within themselves to heal. And that's fine too, but we just need to make sure that our treatment aims are aligned with their treatment aims, and that really and truly the patient is being kept at the centre of what we're doing. If you have any queries, please don't hesitate to contact me. So midwest.podiatry@hsc.ie, all referrals can go there. Darren.mclaughlin@hsc.ie if you have any questions for me. And our Twitter is @MidwestFootClinic. Thank you for having me.
Thank you for that, Darren. Great presentation. Just a reminder for everybody, please put your questions into the chat box as we're going along, and we will answer them at the end of the third presentation. Our next presenter is Adele Brannigan. Adele first qualified as an RGN from Bart's Hospital in London. She then specialised in cancer nursing, and on returning to Dublin, she became bone marrow stem cell transplant coordinator in St James's. After getting married, she started working as a community nurse in Shannon Health Centre. Adele then spent the next 16 years working in the community and developed a special interest in wounds and leg ulcers. She completed a master's in tissue viability and wound care from the RCSI and went on to become the first community tissue viability nurse in County Clare. She has recently become an advanced nurse practitioner in tissue viability and vascular care, and she hopes will enhance wound care and leg ulcer management in the community. Adele would also like to acknowledge that the photos used in this presentation are from the Activa Cross Checker tool and also the Jobst Legs Ulcer brochures. Thanks very much, Adele.
Hello, my name is Edel Brangan and I'm the Community Candidate AMP in Vascular Medicine and Tissue Viability. And today I've been asked to talk to you about venous leg ulcers and lower limb injuries. So what is a leg ulcer? A leg ulcer is defined as any lesion between the knee and the ankle joint. And then a venous leg ulcer is an ulcer on the lower limb that occurs in the presence of venous disease, and we'll go through later on what the signs of venous disease are. And this is a wound that takes more than 2 weeks to heal. A venous leg ulcer, we know, are the most common types of ulcers that we find in the community, and this is backed up by a lot of UK studies, international studies, and a survey we carried out in Clare in 2016 highlighted that over 76% of all ulcers in the community are venous leg ulcers. So what's a venous leg ulcer? A venous leg ulcer is, it usually occurs as a result of somebody having venous disease or chronic venous insufficiency. And this is a condition that occurs when the vein walls or the valves in the veins are not working effectively. And when this happens, it makes it very difficult for blood to return back to the heart from the legs. And so with this, you get pooling or a collection of blood in these veins. So the diagram here just highlights the difference between a healthy working normal vein on the left and then a vein with poor ability to push that fluid back up the leg. You can see where the valves are just incompetent. They're not able to push that blood back up the legs. Now in a normal individual, you have obviously your arterial flow and your venous flow. And that's represented here. In the red is your arteries and in the blue is your veins. And this system you have in both legs. So if it's a thing that we have a system whereby the arteries are pushing blood down the legs and the veins are unable to push the blood back up the legs, we're obviously going to get some signs and symptoms of what we call venous disease. And these symptoms include, quite logically, is swollen legs, because if fluid and blood can't be pushed back up the legs, it wouldn't be unusual for people to have what we call swollen legs. And a lot of people we see would have swollen legs, and we may or may not act on it. Ideally, we should be acting on it sooner rather than later, because if people are presenting with swollen legs, they have the start of what we call venous disease and complications because of it. They may get a feeling of tight calves, itchy, painful legs, pain when they're walking, but then it stops when they rest. So these are all indications that their venous system is under pressure. You may have little signs like ankle flare. You may find that they have varicose veins. Some people say that their varicose veins are actually warm and tender to touch. They may have an uncomfortable feeling in their legs. They may have cramps, or they may develop spasms. And all these are signs indicating that they may have venous disease. The other thing that a lot of people present with, but it's not always acted on, is actually skin changes. And if you can imagine, if you have blood pooling in veins around your legs and the blood is pooling there, you may get a seeping out of that fluid out around the surrounding tissues and the capillaries, and this often causes hyperpigmentation, which is just a redness or a heat to the skin. It may cause venous dermatitis or varicose eczema, and all is this is a symptom that, you know, the veins aren't able to push the fluid back up the leg, the fluid is seeping out, and it's causing irritation to your skin. A lot of the time patients may get a prescription of steroid cream from their GPs to treat this, but really it's only treating one of the symptoms, and really the underlying problem is venous disease, and they do need support stockings to really address the underlying problem. The other sign is actually what we call hemosiderin staining, and this is often presents as a brown discoloration to the skin. This is actually where we have the hemoglobin of the blood that's pooling in the vein, and the hemoglobin is actually staining the skin. It's permanent. You can't get rid of it, but you can prevent it from developing any further, and you can prevent it by providing the appropriate compression. Another sign of venous disease will be a scarring type condition called atrophy blanching, and this is an area of scarring that often arises in the lower leg, and it's usually an indication of poor blood supply, particularly after a previous wound healing. And then, of course, if all these signs and symptoms continue and we don't act on them, usually it ends up with somebody developing an ulcer. Now, obviously, an ulcer can occur after a trauma, after somebody may have banged their lower limb and the healing ability is reduced, and that's one way that people do present with venous leg ulcers. But alternatively, they may present with a spontaneous development of a venous leg ulcer. So what causes venous insufficiency? And I suppose one thing that does cause it is excess weight. So anybody who is quite heavy, they're obviously putting extra pressure on the venous system. So if you have a lot of weight on your waist, around your waist area, it's very difficult for the veins to push against that weight to bring blood back up the legs. And that's why in pregnancy, it can also put extra pressure on the venous system. So people who've had multiple pregnancies are more susceptible. If you have a family history of venous insufficiency, it can make you more susceptible. And obviously anybody who's had a damage to their leg, so this could be a broken limb, it could be a knee replacement, it could be a fixation of the ankle, anything that interferes with the venous system, that includes a phlebitis, a blood clot, all of this will actually make you more susceptible to venous insufficiency. High blood pressure in the legs, and what we mean by that is people who put extra pressure on their legs. So anybody who's standing for long periods of time, such as hairdressers, bartenders, nurses, anybody who's standing for long periods, or anybody who's sitting for long periods of time. So if you have an elderly person sitting at home for long periods of time and not getting up and moving, they're putting extra pressures on their legs, and this all makes them more susceptible to venous disease. Anyone who has a lack of exercise or lack of mobility, the one thing that's really important in venous disease is actually the movement of the calf muscle, and there's a mechanism there called the calf pump action, and that calf pump action is really important in pushing fluid up the leg. So if people are not moving and not using their foot to get that calf pump action, they're making the likelihood of venous disease more likely. And obviously smoking, because of the constriction of blood vessels, makes them more likely to have venous disease. So the question is, do your clients, family, friends have any signs of venous disease? And if they do, they are at risk of slower healing rates if they ever develop a traumatic wound. They may be at risk of swollen, painful limbs and possible ulceration. So what can we do? And the treatment really is very straightforward. It's not complicated. If you've got venous disease, your veins need support. So as nurses in the community, one of the things that we always do is we carry out a full leg ulcer assessment, and this includes an ankle brachial pressure, and that's to rule out any arterial disease. And once we're confident that there's no arterial disease, compression therapy should be first line treatment for all venous ulcers, and it should be applied sooner rather than later. So as soon as there's an indication that somebody has a lower limb wound and there's venous disease there, they should be commenced on 40 milligrams of compression therapy straight away. So venous disease, once the wound is healed, they will need to have ongoing support for the rest of their life. So the use of 40 milligrams compression is the gold standard treatment, and this is recommended by the HSC. It's also recommended by the Wounds UK, NICE guidelines, and it is the gold standard treatment for venous leg ulcers. And regular exercise and the exercise, that calf pump action, should be encouraged to improve the blood flow. And oftentimes there are surgeries that can help with the management of problem veins, and this includes laser ablation. It's a minimally invasive procedure, and this is where a catheter puts heat into the affected vein, and this actually closes the vein and stops blood from pooling in that vein. And once that vein is closed, the blood circulates to the surrounding veins, so the blood flow continues, but it just means it's not pooling in that problem vein. An alternative therapy is called sclerotherapy. And again, it's a minimally invasive procedure, and it's where you inject a chemical into the affected veins, and this chemical causes the veins to scar so that, again, they can no longer carry blood and blood can no longer pool there. And the body then goes on to absorb the scarred veins. And the one thing to remember here is it's now recommended that even if you do have vein surgery of any kind, lifelong compression is needed to prevent further ulceration and further signs and symptoms of venous disease. Compression in diabetes. Compression therapy in diabetes should be used, and the one thing we do need to do is we need to have a thorough vascular assessment, and that's to rule out any microvascular disease that may occur as a result of the diabetes. But in fairness, compression therapy is used regularly and used very effectively in patients with diabetes. So when we're talking about compression, what do we mean? There are various forms of compression, and over the years this really has exploded to the benefit of the patients and practitioners as well. We can apply compression in the form of bandages. We can apply it in the form of stockings, leg ulcer hosiery kits, wraps. So whatever the patient's abilities in movement or whatever their condition suggests, there is always a form of compression that we can use that will actually benefit them. So when you're choosing a compression system, what you need to do is, the most important thing is to involve the patient and involve them in choosing what compression they're going to have to use, because obviously once they're involved, it's a decision that they will make and they'll be more likely to use the therapy. And you need to take into consideration whether it's oedema you're trying to manage or whether it's exudate. You need to take into consideration the limb and the shape of it, the height of the individual. Are they obese? Will they be able to bend down and put on and take off their hosiery? And also the psychosocial or lifestyle issues. Are they rushing out to work every morning? Will they have time to put on their compression? And obviously their mobility, whether they're arthritic, will they need help? Will we need to get, and we do regularly get home care packages in place for leg care. And the one thing that's really important as practitioners is that we all use positive language. Compression therapy shouldn't be seen as a drudge. It's a supportive therapy which will prevent and improve their lifestyle. We need to explain the treatment and rationale for all stages. And we need to involve patients, family, and obviously the more people that are involved, the better chances we have of the patient agreeing and conforming to treatment. The use of patient information leaflets, and there's so many online resources available that if the patient is able and interested, it's great to give them as much information as possible. And obviously ongoing review. Continuity of care with consistent messaging is really, really important. So it's important that everybody understands the importance of compression and the need for it. And obviously encourage walking and foot exercises. We should never underestimate the power of that calf pump action. And just because patients can't walk doesn't mean that they can't do little foot exercises, whether sitting in their chair or lying in their beds. So the key message is compression garments and bandages and wraps are our best tool in the management and prevention of venous disease. And unfortunately, venous disease, it is a lifelong condition, and so therefore it needs lifelong management. It's not just for when somebody has an ulcer. So I hope this was helpful, and if you need any information, you can always contact any of your public health nurses. Take care. Thank you.
Thank you, Adele, for that very comprehensive overview of leg ulcers. Now for our final speaker. Natalie Morrow graduated from Strathclyde University in Glasgow in 2013 with a BSc Honours in Prosthetics and Orthotics. Since graduation, she has worked in Ireland as a dual practicing prosthetist and orthotist with both the Atlantic Prosthetic Orthotic Services, APOS, in Galway, and Ability Matters at the National Rehabilitation Hospital in Dublin. She has also provided prosthetic services to the Isle of Man, and in 2020, she completed a Certificate of Operations Quality and Lean Management at the Athlone Institute of Technology. In her current role as Senior Orthotist, Natalie specialises in gait analysis and biomechanical correction of alignment in order to prevent occurrence of and advance healing of both diabetic and non-diabetic ulcerations. Natalie will be talking to us today about the orthotic management of non-diabetic ulcerations. Thank you, Natalie.
Hi, my name is Natalie Morrow and I'm a prosthetist orthotist with APOS Limited. I've put together this presentation today on the orthotic management of non-diabetic ulcerations with my colleague Karen Duff. APOS is a private prosthetic and orthotic company based in Galway. We've recently moved from Kilcolgan to Oranmore. Although our main base is Galway, we have satellite clinics nationally working with different MDTs across the country. We aim to provide an excellent standard of care by assessing, manufacturing and fitting custom-made prostheses and orthoses. We have an on-site workshop in Oranmore, therefore we're able to manufacture the majority of our devices in-house. Both orthoses and prostheses are counted as Grade 1 medical devices. So, what is an orthosis? An orthosis is an externally worn device which applies forces to certain segments of the body in order to correct and control movements, as well as limiting unwanted movement and redistributing pressure. This is done through altering the magnitude and direction of forces applied. At the assessment stage, it must be determined which key orthotic goals we are trying to achieve. The key orthotic objectives are to correct or resist a deformity. Where this is not possible, we look to accommodate it. We also look to offload areas of peak pressures, protect vulnerable tissues and prevent unwanted movements. In following these key objectives, we also aim to eliminate pain where it is present. All of these are essential in preventing ulceration as well as assisting in healing of active ulcerations. To correct or resist a deformity, we first look at the level of correction which is achievable and assess which areas will be pressure tolerant or pressure sensitive to determine where to apply our corrective force system. Early intervention can be key to maintaining a normal foot alignment, especially in cases of muscle imbalance or weakness. This is important in reducing the risk of ulceration, as the more deviated a body segment is from the normal alignment, the higher the risk of skin breakdown through abnormal loading and increased pressure points. Using orthoses such as total contact insoles, which are known as TCIs, and ankle foot orthoses, which are known as AFOs, can help reduce the risk of pressure-related ulcerations. Where a deformity cannot be corrected, it must be accommodated. This is to try and prevent further progression of the deformity and reduce the risk of skin breakdown. This can be done through modular or custom footwear, TCIs and AFOs. Redistributing forces can be done in many ways dependent on the area of concern. The larger the region the force can act upon, the less force will be applied to one specific area. Through redistributing these forces, we are looking to protect vulnerable tissues and reduce risk of skin breakdown, especially in those at higher risk of ulcerations or those with reduced healing capabilities. Finally, we want to prevent unwanted movements to try to emulate the normal kinematics of the gait cycle in order to reduce the risk of skin breakdown. Musculoskeletal disorders and imbalanced muscles can lead to abnormal loading of the limb and result in increased peak pressures, which can increase the risk of skin breakdown. Just a quick run through of a few pathologies at higher risk of ulceration. The first is peripheral vascular disease, which is when the arterial supply to the limb is compromised, which results in reduced healing capabilities if ulceration did occur. Therefore, we focus on the orthotic principles of protecting and offloading from the onset to prevent ulceration. This can be done through the use of accommodative footwear, TCIs and bed resting AFOs. Patients with PVD are at higher risk of amputation. Therefore, we frequently see a crossover between prosthetic and orthotic design. In the case of partial foot amputations, these can be treated with a partial foot prosthesis or orthotic intervention such as insoles with toe fillers, sometimes used with a carbon plate, rocker soles or AFOs. Spina bifida is another condition at very high risk of ulceration. This is due to neuropathy, muscle weakness and subsequent muscle imbalance. These features can lead to abnormal loading and altered biomechanics of gait, all of which mean the skin is at very high risk of breakdown. Spina bifida patients also have reduced healing capabilities, therefore early intervention and protection of these patients is vital. This can be done through orthotic intervention using TCIs, accommodative footwear, as well as AFOs and knee ankle foot orthoses, known as CAFOs. Lastly, we're going to look at rheumatoid arthritis. Now this varies greatly in presentation, but deformity at the foot and ankle is commonly present. This includes features such as clawed or hammered toes, bunions, or reduced fatty pads across the met heads. All these features increase the risk of skin breakdown through abnormal loading and increased pressure points. Therefore, accommodative and protective intervention is required. It must also be remembered when treating these patients that generally their sensation is intact. Therefore, these areas can be very painful and require significant offloading. Now, I have touched on a few different types of orthoses going through this, but now we're going to delve into a little bit more detail. Firstly, we look at foot orthoses, focusing on total contact design. TCIs are used to correct or accommodate foot positions and deformities and offload areas of peak plantar pressures through total contact. This increases the surface area for forces to be more equally distributed across the foot, assisting in healing active ulcerations and alleviating pressure in the high-risk foot. To achieve a total contact design, the device must be custom made. In designing these foot orthoses, we must look at the design and specification required and consider our material choices depending on the patient requirements. For example, we need to assess where higher density material may be used to load pressure onto the pressure tolerant areas while significantly offloading the pressure sensitive areas or areas of concern. These areas of concern can then be backfilled in a softer material to provide further offloading again. Design features such as met bars and domes, sinks and donuts must also be considered and positioned where required to provide suitable offloading and pressure relief. As well as redistributing pressure and offloading specific areas, we must look at the biomechanical objectives the insoles aim to achieve. Using wedging or skies can improve the gait pattern and patient's mobility. TCIs can also be used to accommodate fixed deformities of the foot, and when prescribing a foot orthosis, it must be carefully assessed which deformities are fixed and which are flexible. On to footwear. There are several different types of footwear. To begin with, we're just going to touch on offloading temporary shoes, which are designed to specifically offload specific regions of the foot. These are rarely used as a definitive intervention and are generally used in the interim whilst custom orthoses are being manufactured. Stock footwear, things like podiatrist shoes or doctor comfort shoes, are generally used as a step up from off-the-shelf footwear. These provide a wide and deep alternative and it can accommodate small foot deformities nicely. When stock footwear are no longer suitable, the patient will then move on to modular footwear. Modular footwear comes in a wide array of lasts which accommodate many different foot types and deformities. These lasts can then be adapted further and be customised to the patient's needs. You can customise them by adding different modifications such as bunion pockets, increasing instep circumferences, increasing toe box steps, as the patient requires. Custom footwear is used when the foot deformities are more than can be accommodated by modular footwear and suitable modifications. Custom footwear is made to specific patient measures and casts are taken in order for the footwear manufacturer to create a last specifically used for that patient. Typical features of orthotic footwear include wide and deep toe boxes, seamless uppers, soft leather or neoprene uppers, and butterfly toe puffs. Orthotic footwear should also have enough room to accommodate a TCI. They also must have a secure lace or Velcro fastening. Slip-on shoes are never acceptable as they increase the risk of friction and shear. Material choice and spec is very important and individual patient considerations must be taken into account when prescribing footwear, whether this be a specific lining that's more durable or maybe a waterproof lining, or whether a harder lightweight sole is required depending on the patient needs. We must fully delve into the patient's history and requirements before prescribing footwear. So moving on from footwear, we're going to look specifically at sole modifications. Rocker soles can be very effective in helping to offload specific ulceration sites and aid progression in gait. These modifications can be made to stock, modular or custom shoes and can also be added to the patient's own high street footwear when suitable. There are many different types of rockers that can be added to footwear as can be seen in this illustration, but it is very important to be specific about the placement of a rocker in order to achieve maximal offloading. For example, to offload the met heads, the rocker is generally placed 5 mm behind the met heads. In order for a rocker sole to be effective, the sole must be rigid. Another sole modification which can be very useful is the addition of a flare. This increases the width of the sole and can be added either medially, laterally, or either side. The larger the flare, the larger the lever arm, and the resultant force being applied on the shoe and the patient is increased. Medial flares are used to resist pronatory movement, lateral flares are used to resist supination, and flares on either side of the heel are used to increase the overall stability. Moving on to an increased level of support, we look at ankle-foot orthoses. There are many different designs of standard AFOs, including rigid, posterior leaf spring or articulated, and several others. Regardless of design principles, there are certain key objectives which standard AFOs aim to meet. These include normalising gait deviations and improving mobility, restricting abnormal movements at the foot and ankle, redistributing pressure, and slowing or preventing deformities in at-risk groups. There are both off-the-shelf and custom options available, and the decision of which to use is dependent on the severity of deviation and the level of support required. Night and resting AFOs encompass the same basic principles as mentioned. However, they are not used for ambulation and focus more on contracture management and controlling deformities. There are also specific AFOs designed for bed rest and offloading the heel. These are used to reduce pressure-related heel injuries. There are two versions, one of which allows for ambulation, known as a PRAFO, and the other which is purely for bed rest. These are both commonly off-the-shelf devices. Increasing the level of control again, we look at the weight-bearing AFO, also known as a PTB AFO. These are specifically designed to provide offloading to the plantar aspect of the foot by suspending the limb from pressure-tolerant areas around the knees, such as patella tendon, popliteal fossa, and tibial flares. This device increases the surface area through which pressure is distributed and shifts weight proximally onto the shin, as well as restricting unwanted movement at the foot and ankle. It can be used with or without a TCI and is frequently used with orthotic footwear and rocker soles. As well as being used to offload plantar ulcerations, this can also be used to offload and control severe foot deformities and aid in the offloading of non-union fractures. A PTB AFO is also seen as a slightly more cosmetic alternative to a crow walker, which is what we are now going to discuss. The Charcot restraint orthotic walker, also known as a crow, is most commonly used for the offloading of the Charcot foot. Now, first of all, just to state that although Charcot foot is most commonly seen in patients with diabetes, it can be seen in a variety of other conditions. A crow is a custom-made bivalve device designed to provide total contact to the plantar aspect of the foot, ankle and calf. It is made with a custom TCI and shifts weights proximally onto the shin whilst restricting triplanar motion of the foot and ankle. It is used as a weight-bearing device and has an external rocker sole built onto it. This is not just used for Charcot foot but can also be used in offloading severe foot deformities, ulcerations and non-union fractures. So this is a brief overview of the orthotics which can be used in the healing and management of non-diabetic ulcers. But I would like to state that the principle of offloading a non-diabetic ulcer is very similar to that of offloading a diabetic ulcer. The main thing I would like to finish with is the importance of working as an MDT to treat these patients. As I said at the beginning, APOS has many MDT clinics across the country, but one which I would like to highlight is the monthly clinic ran with the podiatry team of SIF343. The collaborative clinic ensures the patient receives the highest standard of care and that all aspects of their treatment and the plan going forward is taken into consideration. This helps us to identify high-risk patients and how to prioritise their needs. Joint clinics is something we strongly advocate for at APOS as we feel it provides a gold standard of care to the patient. Now, obviously with COVID, joint clinics and clinics in general have posed a few new issues. However, we are working through these with the proper protocols and procedures, and as an essential healthcare service, we are still providing clinics to high-risk patients. Thank you all very much for listening, and I will be happy to answer any of your questions at the end.